So just some examples. Can Doppler help in these women with symptoms, positive pregnancy tests, no intrauterine pregnancy? These are cases that we've seen in the last few slides. When we see, in this case, there's a gestational sac with a heartbeat, the likelihood of ectopic based on the grayscale ultrasound, 100% Doppler will certainly not help. What about this case? There's a tubal ring indicating a 95% chance of ectopic. Will Doppler help? No. What about this case? There's a normal adnexa. Here's a cyst, follicle in the ovary, maybe a corpus luteum. There's nothing to Doppler in this case. It won't help. Doppler in this case could only potentially mislead us. Here we see the ovary in a roulette ectopic patient. There's probably a corpus luteum. There's a tubal ring beside it. If you, this indicates a 95% chance of ectopic. Now what if you happen to turn on the Doppler? And when you turn it on, you see there's some flow in places beside this, but no flow around it. So there's no surrounding color. In this case, which do you believe? The grayscale finding that would indicate a 95% chance, or the Doppler that shows no surrounding color? Well, you better believe this one, the grayscale, because this patient has an ectopic pregnancy. It's probably somewhat of a chronic ectopic, and that's why there's no blood flow. But more importantly, we're going to believe the grayscale, and since we're going to believe the grayscale regardless of what the Doppler shows in this case, there's no point in doing the Doppler. So the diagnostic approach for ectopic pregnancy is to scan transvaginally and put the ultrasound into one of 4 categories that I showed above, that I showed previously. If the transvaginal scan is inadequate, for example, there's a fibroid in the lower uterine segment that doesn't allow you to see well through it, do a transabdominal scan. And if the transvaginal ultrasound is equivocal for an adnexal mass, which doesn't come up too often, then you can do Doppler. And I'll end by talking about some unusual ectopics. Everything I've said so far about ectopic pregnancy relates to the usual 95% of ectopics in the tube. There are unusual ectopics include abdominal pregnancies, corneal ectopics, cervical ectopics, heterotopics, and pregnancies implanted in cesarean section scar. So an abdominal pregnancy can be surprisingly difficult to distinguish in some cases from an intrauterine pregnancy, as we'll see in this slide. If you look at the slide on the left, this is about a 15-week pregnancy. There's the baby's head, the body, there was a heartbeat, things looked normal. And at first sight, you could say this is a normal intrauterine pregnancy. There's the cervix, there's the body of the uterus with the pregnancy. But on closer look, you can see that this is not the cervix, it's actually the entire uterus. There's the fundus of the uterus, and this is an abdominal pregnancy lying free in the abdomen. Cervical ectopic pregnancies can also pose a diagnostic problem, distinguishing a cervical ectopic pregnancy, one implanted in the cervix, from a spontaneous abortion in progress, a pregnancy that is sitting in the cervix when you are doing the scan, but it's really on the way of just passing through on the way out. Schematically, cervical ectopic we diagnose when there's a normal-looking gestational sac in the cervix, especially one with heartbeat. We would diagnose a spontaneous abortion in progress if we see a flattened sac with nothing much in it and not much of a decidual reaction or bright ring around it. In words, the diagnostic criteria are that if the ultrasound finding in the cervix is a well-formed sac with a prominent ring around it, especially if we see a live embryo, we diagnose a cervical ectopic. If there's a flattened, irregular sac with a thin or absent echogenic rim, we diagnose a no live embryo. We would diagnose spontaneous abortion in progress. Sometimes the finding is somewhere in between these. If it's equivocal and the patient is stable, we can wait a day or two in equivocal findings when the findings in the cervix are equivocal. If it's unchanged, a day or two later, we diagnose cervical ectopic. If it's changed or absent, we diagnose a spontaneous abortion in progress. Here are side-by-side examples. These images on the left, you can see there's the fundus of the uterus, no pregnancy in the body of the uterus. Here in the cervix, though, is a gestational sac that looks normal, and there's a heartbeat. In fact, it is a normal-looking sac. What's abnormal about it is where it is. It's in the cervix. This is cervical ectopic pregnancy. Here, this patient on the right has a different looking gestational sac in the cervix. It's flattened, irregular, not much of a bright rim around it. On this real-time clip, you can see a yolk sac but no embryo. This is a spontaneous abortion in progress. Corneal ectopic pregnancy, one that is situated in the cornu of the uterus on the right, is another form of ectopic. It can be also difficult to diagnose. It can be difficult to distinguish in some cases between an intrauterine pregnancy that is somewhat eccentrically located or one that's quite eccentric because it's in a duplicated uterus, such as a bicornuate or septate uterus. The way that we distinguish, you can see schematically, corneal ectopic has no visible myometrium around the lateral or supralateral aspect, where an intrauterine pregnancy that's eccentric will have myometrium all the way around it. So if we see an eccentric sac with little or no visible myometrium, corneal ectopic. If there's myometrium around the entire sac, it's an intrauterine pregnancy. And again, side-by-side examples. Here is a transverse or coronal view of the uterus. You can see an eccentric gestational sac on both of these. But more important than it just being eccentric is we see no hypoechoic myometrium around the lateral aspect. That's a corneal ectopic. Here, on the other hand, there's transverse view of the uterus. Very eccentric sac way over towards the right side of the uterus, but you can see good hypoechoic myometrium all the way around it. This is an intrauterine pregnancy in a bicornuate uterus. And the final kind of unusual ectopic is a pregnancy that's implanted in a cesarean section scar. As seen here schematically, this is ectopic because it's not located where it should be in the body of the uterus, in the within the uterine cavity, in the endometrium or decidua. It's up here in the cesarean section scar. That can sometimes be difficult to distinguish from a lower uterine segment implantation or a spontaneous abortion in progress where the pregnancy is in the lower part of the uterus. To diagnose it, we want to see the pregnancy coming all the way up to the serosal surface or even sometimes bulging it. So the diagnostic criteria for a pregnancy implanted in a C-section scar include patient has to, of course, had a prior cesarean section. The gestational sac should be located low and anteriorly in the uterus, just above the cervix, and the gestational sac and the surrounding echogenic ring of trophoblastic tissue should extend to the serosal surface of the uterus to make the diagnosis, as in this case. You can see this gestational sac is in the very lower part of the uterus, just above the cervix, and it looks like it's extending up to the serosal surface. You can see that better on this close-up view. There's a heartbeat. There's the serosal surface that's bulging a little bit by this, with the trophoblastic tissue extending all the way up there. This is a pregnancy implanted in a cesarean section scar. These are very important to treat. Here you can see a 5.5-week pregnancy implanted in a cesarean section scar. 2 weeks later, at 7.5 weeks, it's growing and starting to bulge. The sac, the woman was advised to have this treated at this point because of concern for subsequent rupture of the uterus, but she elected not to. And by 11.5 weeks, the uterus is bulging way out, and this was far enough along that the only way to treat this was via hysterectomy. So I've come to the end of the discussion of emergency obstetrical ultrasound in the first trimester. Hope that it's been valuable to you in seeing the ways to accurately diagnose the two things we're worried about in emergency scans in the first trimester, namely failed pregnancy and ectopic pregnancy.